So friends, today we will it's a small talk on immunotherapeutics of Prurigo nodularis and the new molecules we can try in the Indian context. So at the outset, that's the overview of the adaptive immunity arm, wherein the Th naive cell subdivides into various cell types based on the cytokine milieu. Now, grossly, the Th1 mediates a lot of CMI induced disorders. Th2 is usually seen in pruritic conditions like atopic dermatitis and prurigo nodularis. The Th17 cytokines and the cell itself is used for psoriasis and psoriasiform conditions. And then the T follicular helper cell is actually a B cell co-stimulant. And then, of course, you have the other two cells. So, the importance of this particular diagram is to understand that a cytokine transduction pathway mediates and predetermines the different T cell types. So now let's look at how this all began. Of course, a decade back, we also think that there is an itch-scratch cycle which mediates prurigo nodularis. So in other words, the itch is primary and then the scratch is secondary. But nowadays, of course, there's a different view. So the four major factors for prurigo nodularis as of today is, of course, the immune cells, which is not just Th2, also Th17 and Th1. Of course, the nerves have got a role to play with their mediators. Then there's dermal fibrosis and, of course, epidermal hyperplasia. Now, let's understand which of these are the most important steps. Now, this is a picture of prurigo nodularis, three different patients, and refractory to most therapeutic line of management, and you can probably just revise what you would do for these cases. When one biopsies a patient of prurigo, what normally we look at is an epidermal proliferation. But this is a schematic diagram which tells you exactly what really happens is a marked nerve proliferation and, of course, various immune cells. And this is one of our papers published where we did a histopathological assessment, and we primarily the infiltrate that you see in the dermis, it's composed of lymphocytes and the various other inflammatory cells, but we did this study look at the nerve proliferation and the mast cell proliferation, and we found a marked S100 accentuation and mast cell activity in the dermis, which of course is a subsidiary step of the Th2 pathway. So let's understand now the Th2 pathway. So that's the CD4 naive cell, and that differentiates into various cell types, as I showed previously. But in this condition, usually Th2, and here you can see the Th2 cell and the cytokines that mediate the action by the JAK-STAT. They stimulate these three cells, the basophils, eosinophils, and mast cells, and then that secretes four cytokines, 4, 5, 13, and 31. If you remember, atopic dermatitis also has identical cytokines, and then the periostin, which is actually a fibroblast stimulator, and the oncostatin M. And then you have the nerves with their mediators, and then of course that causes the epidermal proliferation. So that in simple terms is the immunopathogenesis of prurigo nodularis. Right, so now this is a glimpse of what work we did on the immunology of prurigo nodularis. Now here again is the cell, the same Th2 cell, which in a magnified view shows you the components of the cell, that is the cell itself and the afferent cytokine IL-4/13, which acts via one of the receptors signaling pathways, that is JAK-STAT, and you have the JAK1, JAK3, and the STAT136, and then of course secretes the effective cytokines. Now there are two ways of studying the immunology of any disease. One is you study all cytokines, or study all the cells, or study the receptors. We in this case looked only at the STAT receptor as a surrogate marker for the immune response. So this is the study actually, and what you would see in the study is that we studied 136. The STAT 136 is a surrogate marker for different CD4 subtypes, and we found a marked expression of STAT6, which suggested that it's a Th2 response. This is the first study of immunological study of prurigo nodularis in Indian population. So all this is important to understand what I'm sure a lot of you must be wanting to listen, immunotherapeutics. Because if you do not know immunology and you do not do immunological studies, what you do is experience-based dermatology, which is okay, but not always effective. So from experience based and eminence based to evidence based. So we come back to that cell, and I'm showing you the way the cytokine intercalates. So the IL-4 comes and hits the TH2 cell via the signal transduction pathway, which you see here, the JAK-STAT, secretes effector cytokines. And this is, for the sake of this lecture, good enough as a focus of therapeutics. Now, one option is this, that you be selective. So one option is you block that transmission by blocking JAK receptors. Option 2, you look up for a biological drug that blocks cytokines, or what we've been doing for the last many years, just blocking every cell by giving ISA steroids. So we are moving towards a more specific kind of therapeutics. And so I'm going to now show you the different therapeutic drugs based on the core immunology of this disease. So the topical drugs, are listed here, and usually the drugs are classified into two forms: the neural inhibiting drugs and the immunological inhibiting drugs. So steroids work probably in both. Topical camphor menthol is a very good option, available in India, various preparations. One of my favorites topical agents in such cases is Prurigo. Very useful for doing authentic studies where you give topical camphor menthol and not steroids. Salicylic acid has been tried, but it's more like an exfoliant. The ketamine, amitriptyline, lidocaine topical combination is not there in this country. It's used in the West. Phototherapy has been shown to be effective, but we have not used it much. Now, these agents work very well for localized disorders, but for generalized prurigo nodularis, one needs systemic therapy. And I'm going to show you the first, second, third line based on one of our papers published recently, and of course, a review article by Brooks and et al. Published recently. So in the first line, you have neural agents, gabapentin and its variants. You've got cyclic antidepressants, pretty effective drugs. Some of them are very effective, for example, amitriptyline. Immunological, dupilumab and nemolizumab, I know they may not seem relevant in our country, but they have been FDA approved. Then again, second line, you've got thalidomide. It's classified as a neural drug, but it works on both mechanisms. Then you've got methotrexate and cyclosporine. And then, of course, third line, you have opioids, NK1 receptors, and many more fancy drugs, and of course, JAK inhibitors. So I'm going to show you where these drugs actually work. So this was the index cell, and let's look at the drugs. So you remember IL-4, 5, 13, and 31, they work via intercalated pathway of JAK-STATs. So they all work via different JAK-STAT combinations, and that's the reason why JAK inhibitors are so effective in case of Prurigo. These are three drugs which are being used, out of which we don't have Upadi and povorcitinib, but we got Tofa, and it works as well, believe me. Then you got these new cytokine inhibition drugs, dupilumab, which inhibits IL-4/13, FDA approved, nemolizumab, IL-31 approved by FDA. The second one is not yet approved on trials. You've got an OX40 inhibitor, which is basically a drug that causes loss of effector T cells. This is again on trial. Then you have another c-KIT inhibitor, which is basically on the mast cells, again on trial. And then you've got conventional drugs. Now, using them in practice is very important, and to use therapeutic agents in practice requires a few provisos. So now come to, of course, how to decide therapy. Now, therapy for any immunological disorder is based on three important factors. The first is a good knowledge of immunology. Immunology as a field, even immunology as a field, actually has become a big thing in the last 20 years. So it's good practice to revise that. Second is cost effectiveness. Most of the drugs approved for US FDA approvals for Prurigo are extremely expensive. Dupilumab is ridiculously expensive. Month's course can put you back by ₹500,000. Nemolizumab is not there in the country. So one should choose drugs carefully, and in that respect, nothing beats JAK inhibitors. Most important is ADR profile of the drugs, and of course the patient's comorbid condition. So this is one of my books, which you can refer to when you get time. It's exhaustive summary of different drugs, the actions, and the immunology, of course. Now let's look at these index cases. This is the first case. It was a patient with prurigo nodularis all over the body, and I'm showing you the lower back. Extremely itchy. Refractory cases which had failed the conventional drugs that you give. pregabalin, nortriptyline, sensival, antihistamines, the works, and this patient responded to tofacitinib. We begin always at an OD dose, 5 mg OD, and then make it 10, maximum 15 mg, and they respond beautifully. This patient had not just a response, extremely long remission rates. It's part of our study published recently in the IJDVL, with, of course, translational data. Another case of Prurigo nodularis, wherein we used thalidomide. This was before the JAK inhibitors became so cheap in a country. Extremely pruritic case, who was given very low dose thalidomide. In fact, you'll be amazed to know this particular paper, we just used 50 mg in most patients and a few hundred mg. So the idea is you can use the knowledge that you have. Of course, there are other drugs you can try. I'm not saying these are only two drugs you can try, but uh, the whole idea of this particular talk was to show how you can go beyond the usual uh, drugs that you use for Prurigo and go to drugs that are extremely effective. Of course, you can follow the step-by-step guidelines and use them, and then of course utilize your basic 3 steps to guide therapy. So that was my brief talk on Prurigo, and thank you very much.